Hi, my name is Lori Bailey. I'm the director of the Psychiatric Mental Health Nurse Practitioner programs at Franklin University. Welcome. The role of the Psychiatric Mental Health Nurse Practitioner is one that carries with it both great reward and tremendous responsibility. As we prepare you for this important position, we're going to introduce topics that may create some discomfort as a result of the necessary self-reflection. But the potential benefit of these discussions for you and for your future patients can't be minimized. One of the topics we'll be pursuing, implicit bias, challenges us as providers to explore our unconscious belief systems and biases. Implicit biases, which we all have, explain a potential dissociation between what we say we believe explicitly, that we want to treat people equally, and the hidden influences of negative implicit associations or on our thoughts and actions. For instance, a provider who perceives a Black patient as less competent, who then decides not to prescribe the patient a certain medication. According to Fitzgerald and Hurst in their systematic review, even with all of the discussions throughout our professions about diversity, equity, and inclusion, we still, physicians and nurses, manifest implicit biases at rates that are similar to those in the general population. So somehow we're not doing what we need to do. And this affects a lot of people. The characteristics that typically end up the target of implicit bias are people who are in any way considered other. Race and ethnicity, gender, socioeconomic status, age, the presence of mental illness, weight, having AIDS or HIV, brain-injured patients who are perceived to have in any way contributed to their injury, IV drug users, patients with disabilities, and patients in social circumstances that are outside of the norm. Think about the last time you saw a homeless patient and how they were treated in a healthcare environment. The research indicates that provider biases can lead to misdiagnosis and inadequate or inappropriate treatment for our patients. Recognizing the biases that, without any intention or awareness, have resulted from interacting in society, and starting to work on strategies to mitigate those biases has the potential to literally save patient lives in healthcare. In psychiatry, we're all one inadvertent eye roll away from losing a patient who probably needs our help. We have to learn to understand our own cognitions and work to mitigate the negative stereotypes and biases that have accumulated. This process has the potential to have a tremendous impact on patient outcomes. For example, some of the types of biases described in the literature. Providers are more likely to diagnose Black patients as violent or psychotic. Women are more often seen as hypersensitive or overreacting, and so don't get the treatment that they need for true mental illness. Black people are more likely to be diagnosed with a substance use disorder without recognition of some of the very common comorbidities like depression, PTSD, bipolar disorder, etc. And if we treat the substance use disorder without dealing with those comorbidities, we've set the patient up for failure. So the patient starts to use again, which confirms the provider's bias. So the cycle continues with subsequent patients. In addition, people with disabilities are more likely to be treated as if they're less intelligent or capable. Elderly patients are more likely to be treated as if they're cognitively impaired, even though we know that cognitive impairment is not a normal finding in healthy aging. In the end, our hope by including this exploration, this topic, this discussion, is to create a brave space rather than a safe space. Together, we will create a brave space, as this poem goes, because there's no such thing as a safe space. We exist in the real world. We all carry scars and we've all caused wounds. In this space, we seek to turn down the volume of the outside world. We amplify voices that fight to be heard elsewhere. We call each other to more truth and love. We have the right to start somewhere and continue to grow. We have the responsibility to examine what we think we know. We will not be perfect. This space will not be perfect. It will not always be what we wish it to be, but it will be our brave space together, and we will continue to work on it side by side. That's the goal. Again, my name is Dr. Lori Bailey. I'm the program chair, and your feedback, any concerns, or any questions are always welcome. I can be reached at lori.bailey@franklin.edu, and I welcome the discussion. Thank you all, and take care.